Hi, everybody. I'm Jessie. I'm the moderator. I am a psychiatrist who specifically sees healthcare workers, and I'm the Chief Wellness Officer for the University of Tennessee system, so the 5-school system of University of Tennessee. I'm going to let everyone else introduce themselves, and then we'll get going, and we'll have some audience questions at the end. We like a microphone more than this thing, but we'll see if we cause problems doing that.
Well, good afternoon, everyone. Monty Maston. I'm the Chief Medical Officer with Marsh McLennan. So I lead a team of physicians, registered nurses, data analysts, and population health experts, and we work with employers of all sizes, all industry sectors across the U.S., and we use tons of data to find ways for them to get their employees healthier. So pleasure to be here with everyone this afternoon.
Well, good afternoon, everybody. Tamer Atala. I have the privilege of serving as the Executive Clinical Director for our Behavioral Health Clinical Program at Intermountain Health. Intermountain Health is an integrated health system in the Intermountain West with 33 hospitals, 400 clinics, a health plan of about 1.2 million, about over 68,000 caregivers, who we call as all of our employed folks in our system. So it's a pleasure to be with you.
Hello, my name is Dawn Carlson, and it's my privilege to lead the HR practice at the Hazel and Betty Ford Foundation. Hazel and Betty Ford is an organization that is the largest not-for-profit substance use and mental health provider in our nation. And it is just really an honor to work in a segment business where we really help people restore their hope and their futures, and it changes lives. And so I have the privilege of working with over 1,700 people like Tamer who provide care, and I'm excited to have this conversation today.
Good afternoon. I'm Ryan Dix. I'm a psychologist by background, but I am here as a Director of Behavioral Health for Providence St. Joseph Health System, which is a large health system on the West Coast, from Alaska down to Texas. We have 51 hospitals, over 1,000 clinics. We also call our employees caregivers. We have over 125,000, including nurses, physicians, and so forth. And so I get the opportunity to oversee a lot of the mental health and wellness initiatives for those caregivers in partnership with our HR colleagues.
Hi, everyone. Jenny Ahn. I am a leader at Deloitte Consulting, so a bit of an outside-in perspective. I have 2 jobs. I have a day job and a separate job that takes just as much energy. My day job is I consult with our life sciences healthcare organizations. Call it probably your largest provider organizations, your largest biopharma, biotech companies on what I would call anything that is about making people better at work and work better for people. That could be process optimization. It could be technology adoption. It could be leadership effectiveness, team effectiveness. Basically, anything about your workforce is a lot of the work that I do. That is my day job. My second day job, which is much more internally focused, is I'm also the Chief Wellbeing Officer for Deloitte Consulting. That's 40,000 people here in the US and another 40,000 outside of the US. And I'm attentive that what we work on is just as important as how we work. So we're very attentive to the well-being of our own people. So here to bring a bit of an outside-in perspective as far as what we're seeing organizations do. So thanks for having us. And Jessie, back over to you.
Thanks. Who thinks they actually know the definition of burnout? Because I think we use like 100. So I'm just going to center us on this conversation for a second before we move, just to make sure that we all know what we're talking about. So I think burnout's used like a lot of mental health terms where people just use it and they think they mean that work was hard. But when we're talking about it from our perspective, it's much more complex than that. So it's a constellation of 3 things. The first one's emotional exhaustion. Just feeling super spent at the end of the day is like the best way to describe that. The second one, depends on who you ask, is either depersonalization or cynicism. Cynicism being anger, depersonalization being like removed from the situation. So as a clinician, we learn to do that, but it's like you do that all the time. And the last one's a reduced sense of personal accomplishment. So getting less done, feeling like you're getting less done. Someone told you you're getting less done. In my patients, in my experience, that's the one that triggers people. So the other 2, I think we go, oh, work is supposed to be emotionally exhausting. I'm a clinician. Oh, like we learn to depersonalize and maybe I'm just a little pissed off today. And the third one is like, oh, somebody said something about my work or I'm not getting work done. That's bad because we measure everything by work. So that's the definition that we use when we're doing studies. That's the definition that we'll kind of use when we're talking about this stuff. With the level setting there, like, why do we even care about burnout? Like, what's the point of this panel?
I mean, just at the fundamental level, I was sharing this with the group earlier. When we think about the fears and the anxieties that we had during COVID, the fears on our physical health and the anxiety that was associated with it, within our organization, we had more people die by suicide than by COVID. So you think about the impact on healthcare was significant. And again, I recognize that's sort of one end of the spectrum, but it's real, and it impacts people's lives in a way where they're intending to serve others, and yet for those groups, that was the major risk. And so for us, and within Intermountain Health, it was something that was really, really important to us. So for me, as we anchor to your definition, Jesse, I think for me, that was a reality for us that we really had to kind of wrestle with and think real seriously about.
Anyone else have strong opinions about why we talk about burnout or why that's part of what we do in our jobs?
Well, I would just say any human, and particularly one that's a provider, is not really capable of giving if there's no wellspring at all, right? You can't give out of an empty vessel. And so it really matters, because if we care about the efficacy of our treatments, the quality of care for patients, like, it has to be able to come from a place that there's growth and there's energy.
Yeah. Anybody at the end? You don't have to. I'm just being annoying.
I think, in addition to obviously the human component of it, there's a very strong business case to be made when it comes to addressing burnout, both in terms of the efficacy of the interventions that we have available, but also just actual ROI when it comes to the business itself. And that's just not specific to healthcare. We see that in many other industries as well, that intervening upon burnout really isn't a nice to have. It has to be something that we focus on if we really want our businesses to thrive. And again, we know in healthcare we see that whether it's physicians leaving medicine, nurses leaving medicine, it has real impacts on our ability to serve patients, but also on the bottom line also.
And also people not wanting to enter the profession.
Yeah, so on both ends, leave and they don't want to come, right? And so I heard leaving it's costly in terms of people joining the field. It's costly in terms of cost. It can affect patients if we don't take care of ourselves, and it obviously affects the individual too. So all those levels are really important when we're thinking about it. Do you have something to add?
Yeah, I was just going to add, I think you have to go beyond just looking at the providers and burnout and think about health systems and the whole ecosystem of the employees that are working there. We get really granular with data. We take in data from over 150 different organizations, so it's not just medical and pharmacy data, it's workers' comp, disability and leave, worksite clinic, 401k participation, wellness program. And it's really interesting because you can get extremely granular with the data. You can look at by salary bands, you can look at it by geography, gender, job description, and so forth. And so sometimes you think it's the physicians, the nurses that are really being burned out, but it may be someone in environmental services, or maybe the LPNs or someone like that. So really understanding where the trend is coming from. I think when you're talking about any kind of program to implement among the workforce, you really need to understand where the trend's coming from. That's where data is really helpful.
Yeah, and speaking of data, like when we're looking at this kind of big system, how do we actually identify who's burnt out, and like what measures are you using? You're a big data person. Anyone else who would like to comment on data can too, though. Well,
A lot of it, again, is medical pharmacy claims and data feeds, other data points that we look at. But some of the trends that we're seeing, if you take healthcare out of the equation for a second, think about other industry sectors. A lot of mental health claims are utilization is coming from 20 to 35-year-old men. And when you think about it, they're young, they're healthy, they haven't invested in a primary care physician relationship. So if they feel stressed out, anxious, depressed, maybe they start using something, they end up in the emergency department. And then you also have to think about people that are high-cost claimants, people with diabetes and cancer. If you're struggling, battling cancer, you're anxious about test results, stressed out, if you're diabetic and you're depressed and you miss your insulin, you can easily end up in the ICU with diabetic ketoacidosis. So you have to think about, just go beyond burnout, I think, when you're talking about the broader employer landscape.
Jesse, I would add depending on what part of the organization you're in, you're also looking at lagging indicators and predictive indicators. So one of the things that we see is unused PTO days, right? It's a predictor, or it can be a predictor of people who are most at risk for burnout because they're not taking the time, right? How many shifts, how many hours, how many days are they working without a break? And in what world is it okay that the average nurse is on shift 12, 15 hours a day, no bathroom breaks, no food breaks, where you can't even just go for like a quick, a human need to go get food. And in some places, that's considered torture. So there's also something about how do you change the work, how do you change expectations of a profession and say, oh yeah, how do you prevent burnout, but also how do you look at what the work is, and can you be more bold in a profession that has not changed the way it's worked since like penicillin?
Wait, are you saying that just because that's how it's always been doesn't mean it's how it should be?
Shocking, isn't it?
It's weird.
Shocking.
Yeah.
Shocking.
That's fair. Yeah.
I was going to add, the other data components, there's claims and there's information that we learned, but there's also, these are all sort of data points to give us a sense of a picture, right? We don't necessarily know all of it. So some of it is data from direct feedback from those that are doing the work, whether that's survey, which has its limitations, but also rounding and meeting with people to knowing how the work is done. I want to just highlight what Jenny said. What we found, in not only to identify where burnout is, but what the source of the burnout is within the context of work, which then drove our interest of how do we intentionally simplify the work. It was a third of the challenge that was reported. How do we intentionally, and to recognize that we call it sort of the one more click syndrome. I just do one more click to meet this need. Well, that's not that big of a deal, but it was among 43 other clicks that were necessary over a period of 7 years that it sort of built up over time. And so just recognizing that and really listening and not making presumptions on that. So just being really curious from a leadership perspective and gaining those insights in many different ways, but getting it from those that are doing the work.
I think it's important, and you can find out some really interesting things through surveys. I remember a few years ago we did a survey for healthcare, and you would think that a lot of stress is around pay. And it was interesting because you look at the nurses, and that was actually ranked lowest on their stressors. They were stressed about mental health, physical health, the workload, et cetera. But the lower waged caregivers, LPNs, and so forth, that the pay was actually number one. So it's really interesting what you can see when you segregate you segment the data and the surveys. Interesting information.
Well, and to prep for this panel, I read a couple of fairly recent survey reports about what providers said. And in one of the reports I read, they talked about over 60% of the providers said their main driver for burnout was exactly what you described, that sort of one additional click syndrome, or just really a crappy EMR. Now, I don't know many providers that actually like their EMR, so I do want to say that. But just the fact that administrative burden that felt really taxing never seemed to go away or get better.
John, can I add to that? So research that Deloitte's done on this, the survey folks, the clinicians, the physicians, people who are giving care had said they believe that 32% of their day is actually going to low value or administrative requirements. 20% of their day is actually going to work that could be automated or done by somebody else. And one of the things that we see are what I would consider small moves that have big impact, that in their EHR, their electronic health systems, they changed a notification on, they automated one of the notifications to go straight to the case managers instead of to the caregivers, and it saved them 1.7 million clicks a year.
That's a big number.
Just by changing where notifications were going to in their system. And small things like widescreen monitors. well, yeah. Bring me a $200 widescreen monitor and that's going to make your life easier, bring it on. Yeah, because it let them have more windows so you could have the EHR going while also looking at results and what have you. And the other thing too about tuning into what's happening at the front line is also things like, I spend half's an exaggeration, that's me using hyperbole. They're spending half their day just waiting for the EHR to load so they can update a record. And the question was, could I just badge in to the system and not do the clickety-clack to get in and wait for the little swirly thing? Can I just badge in so I'm not just doing the same repetitive motion over and over? So like Dawn, to your point, small moves that if you are attentive to the front line, really listening to what folks are saying, they don't have to be big, huge efforts, although sometimes that's also needed. But what are the small things that you could do on your technology that can save capacity, create some energy for your folks that are not, they're telling you 50% of their day is not going to high value things that a highly credentialed person should be spending their time giving care. So I see head nods and I'm like, y'all are like, yes, bring that on. Yeah.
Well, and I think what it reflects too is also a shift in recognizing that for a long time, organizations focused on how do we make individuals more resilient regardless of the environment within which they exist. And so it's focused on individual level interventions. But that's a great example of what the literature has shown us really much longer, but we haven't paid as much attention to it, is that it really needs to be what about the system that the people are existing in that is contributing to their burnout, whether it's this click or whether it's, I get pinged from Epic Chat when I'm trying to round on patients on the floor. So it's all those types of things, and I think it's important from a strategic standpoint when you're thinking about intervening upon burnout is, are we focusing on the individual and expecting them to just become more resilient, and is that our strategy? Which I hope it isn't. Or are we really looking at what in the environment that's contributing to that person's burnout that we can intervene upon?
Yeah, who here hates the word resilient? Just raise your hand if that's true. Yeah, I think we've just we didn't do it justice in a lot of ways, I think, because for me, resilience isn't the system isn't broken, now you fix you. It's the system's broken, how can you survive within it? And we've done a pretty poor job because we taught resilience skills to people in a way that made them feel like they were the problem. And so I do think that we all have this automatic, I hate that word thing with resilience, but I think it's just because we've never actually used it within the context of we can fix a system and at the same time give you some ways to survive the broken one. Speaking of that, besides sort of thinking about clicks, there's a concept called do less stupid stuff, which is kind of what you're talking about. What else have you guys seen work in your respective industries and locations?
This is a really small human example, but I interviewed a couple of our medical providers, again, in preparation for this, and one of them just said, I really have had to set boundaries to bring energy back into my life. So, I don't work when I'm not at work. While I'm at work, I make sure I do get away for 10 minutes and just walk somewhere, get a tiny bit of breathing room. And I think it isn't really resilience, it's personal boundaries and advocacy and a commitment to yourself. And that was one of the most spirited conversations I had with somebody, was her commitments to herself. And, I think that's really easy to preach or say or act like you should be able to do this. I know there are realities, Jenny, and people not being able to get away from their office or practice area. But I do think those commitments to yourself are really key.
Mm-hmm. Yeah, I was sort of reflecting on that comment that Don will appreciate this. I think for the longest time, it was inappropriate for us to be asking how people are doing. Actually have a culture of just asking, we sort of had this, and we still do. We have a great deal of stigma associated with mental well-being. You think about some of the consequences that providers may be concerned about if they're identified as having a substance use disorders challenge or a mental health concern and potentially impacting their license. And so how do we empower, not just implore programs, but how do we empower peers and create environments where there's psychological safety to ask how people are doing in a way to sort of support them? How are we equipping supervisors to help ask the right questions to engage them in a conversation. And it's not necessarily that they're seeking comments from folks that may be struggling, but they develop a real relationship. And so that engagement allows for greater opportunity to share and support and engage in ways that were sort of considered out of bounds not very long ago. We would not ask those questions.
Well, and also, Tamara, answer the question by saying, no, I'm not okay, right? People have always asked, are you okay? It's more and actually mean the question, are you okay? And to really mean and listen to an answer and answer it, I'm not okay.
I love that, Jenny, because that's really the truth. It's not just the casual, how you doing?
Yeah, I'm fine.
There's
I'm
a
fine.
sort of knee-jerk response. But actually asking, as an example, we have regular huddles across the entire system to review a lot of operational issues. And the team will include a topic just to facilitate an interesting conversation, whether it's a routine that you have in the morning, whether it's sort of expressing a particular emotion, whatever the case may be, but really sort of creating an opportunity to engage in a conversation. And then the second part, many organizations, I just read a Becker report on the workplace wellness. They talked about how 73% of programs across the country, employers have some mental wellness program. And yet there's sort of a mismatch to what they're providing is actually impactful. I think you highlighted some of that before. And so how are we really taking that information and sort of engaging in making sure that those are actually aware of what resources are actually available? Just because the resources exist within your organization, we found that most people didn't know that they existed. And so making sure that peers and those direct supervisors actually have that information available to them.
Yeah, I want to step outside of healthcare again for a second, just go into
You're allowed.
A manufacturing client that one of the most sobering conversations I had was a few years ago. It was a manufacturing client in rural Kentucky, and we were out there and we were talking with their HR leaders about people with high-cost claimants, people battling cancer, diabetes, end-stage renal disease, and rightly so. They're driving up a lot of cost, and they have very complex conditions. But that year, 4 out of the 10 most expensive people on the health plan for that company were male employees that had attempted suicide. One was a fatality. He had sought help within the organization for months. No one knew how to get this guy into the system, right? The access points. Didn't know really about the EAP program, what it brought to the table. Didn't know what, Anthem had out in the community, what community resources were available. And so he shot himself in the parking lot, and he survived in that for a week or so, but had those. And so we do a lot of training with something called mental health first aid at work, if people are familiar with that. But the gist of that is getting managers and supervisors more comfortable having those conversations. They're not going to sit someone down and counsel them, but they know how to get them into the community resource, the EAP programs. I think that's one thing that's really helpful we've seen.
I think across the board, just because resources exist doesn't mean anybody knows about them or uses them. You're 100% right on that. We found that in all of the workplaces and schools that I've ever been at. How we communicate with people is not necessarily how they receive the information. And then the question about how are you, how do you feel? In psychiatry we call fine feelings I'm not expressing. Because basically it's not actually a feeling, but we all think it is, and we're scared to be vulnerable. So that's a culture change, and culture change is hard. We're talking some about systems and ways to make systems better, but in talking about culture change, that's scary to people, I think. Literally asking a question in a huddle, if it's not everybody doing it, it feels like it's that one person doing it, and they have the weird touchy-feely team, and everyone else is not, right? And so I think it's really important to think about, broadly how to kind of do both things at the same time, think about culture and think about systems. And since we're at a tech conference, curious, is technology the devil in this situation, or are there ways that technology can be beneficial to helping with the system issues?
Well, there's a lot of buzz about artificial intelligence. I think no matter what conference you go to, it's always a topic of discussion, and I think it does have the ability to change every industry, and certainly healthcare, if there are certain guardrails in place. But there's really, when you think about healthcare, there's really three silos. There's how can you use artificial intelligence to improve patient care? We're not there yet. There's very few user case studies that actually can show AI is going to change that significantly. Then there's the provider space, and I think that's where this may help. And we've talked about how you get people to take some clicks away. They don't have to, do medical notes in their pajamas and so forth. That may be one area that it's going to help. And then there's the operational efficiencies. If you think about the broader health system organization, how do they do things more efficiently on the back end, administrative tasks and things like that. That's the other place. But we're far away, I think, on the patient care impact from artificial intelligence.
Jesse, I want to ask the group a question. I'd be curious, in the organization that you're at, would you say, it's a hand raised question, how many would you say you're very confident that your organization encourages innovation, actively encourages innovation? Like, be proud. I would
This is a biased
say
sample.
30% is what I
This
saw.
is a seriously biased sample. Lots of them are in startups and stuff.
and yet it's not every hand.
True.
Right, and yet it's not every hand, even in a biased sample of at a conference for behavioral health tech, right? So 30%. The question that Monty, and this question around like, is technology the devil? I think to myself, you have to be at an organization that actively encourages innovation, because if you're not, why would you convert the old way that everybody's been doing it, regardless of all the different data points as to like why it's the bad and the wrong, less efficient way of working, to then make a change and say, we need a bot, we need an automation, we need a better way. You need to actually put investment into actually making a change. And I don't know what role you all are in, but that's a real question. Why are we know what the problem is. Why are we not innovating in an area that we know has high need? And I guess it's audience participation. Like, I'd welcome hearing what that barrier is. Is it money? Is it inertia? Is it not having leadership sponsors? I hear it all. And I can't tell from this audience if you're all like, oh yeah, I already know this and I feel this, but I can't move my people internally to make a change.
Well, isn't the answer also vulnerability in the same way that people aren't comfortable answering how they're doing? You have to be vulnerable to change.
Yes. You got to be out there. You got to be out there and take a bold step. So I'm curious, like when you hear us talking up here, are you all thinking, we are doing that. We are moving to AI. We are very forward in automation. You're nodding at me, Jason. Yes, you are. What enables that?
Support from leadership.
Okay. They're like, we got to get after it. There is a better way.
Yeah, surveys, they listen to feedback from the end users and decide that the old way of doing
Is not good enough.
this is the way of doing things.
Okay.
So they're open to that feedback, supportive of innovation.
Okay.
There's a hand in the back.
Uh-huh.
It's the lack of leadership support. Knowing that there's all these issues and saying, that's not our main issue. And so it's the lack of alignment as to what's the priority. And if everything's supported, then that's the priority.
Yeah. So it's down at the bottom of the list, and it doesn't rise to the top.
As the leader of our organization, probably smaller than some of them in this room, I would love for us to innovate, but then I have factions within the organization that say, I know the system that we're using, I've been using it for decades, and I don't want to change.
Yeah.
And then I've got these other people over here that are fighting, saying, no, we need something that's more efficient, more effective, and saves us time.
Yeah.
Well,
I mean,
How do we end that infighting and move forward without losing our heads?
Well, and I think that partly gets to a point I was trying to make also, which is I don't think we do a very good job specifically for providers messaging around particularly the utilization of technology. And I think as much as like EMR was sold as a way to improve their lives, very few would say, based on lots of surveys, that has accomplished that task. So I think when we think about how do we message around technology, thinking about integrating AI into the exam room or those types of things, I think there just has to be a lot of rebuilding of trust and messaging around it that's convincing and isn't perceived to be a way to just capture more billing or those types of things. That oftentimes that's how providers experience it, is this is just an additional revenue generator. This isn't going to make my life better. And so I think as a recovering provider myself, those are definitely pieces that we need to think about as we're going to innovate into this space.
Yeah, I love Ryan's comment about understanding the provider's lens. I know, Jenny, you said, we know the problem. Oftentimes we think we know the problem. And we need to dig even deeper to understand it. And so I agree we understand it at a global level. But I think our challenge is that we need to really listen and understand the nuance of that. The other challenge that we have is this notion of we're going to find the solution and then we're going to go mad and scale it. So we're going to put a blanket over the whole doggone thing because everybody's got the problem that person A, B, and C have. And oftentimes they're nuanced. And so we have to think about having a nuanced response and really understanding those nuances and creating the opportunity to customize where it makes sense, to scale, and then to get feedback and learn, was it in fact effective? And letting the end user be part of that process. And so I think having that space to do that, because I forgot who said this in the audience, if everything's a priority, nothing's a priority. And that's a challenge I have to deal with all the time. In order for me to be successful, I have to say no to 20 things to say yes to one thing, to do that really, really well. And that's really hard, knowing that people really want to do the right thing. And so I think those are part of the tensions, I think, that are involved. But I love the question, Jenny, because I think we really have to take a step back and understand what are these key drivers. And so those have been my experiences as I started to think about driving innovation for success and moving that work forward.
Tamara, can I add one thing? One of the things I hear is the disconnect and lack of trust, or the loss of trust, from those in leadership positions on a different floor making decisions for frontline, to your point around solutions that are just peanut buttered because they're not listening or the frontline's not involved. And I hear a lot around this lack of trust that our frontline workers, our frontline physicians and clinicians are basically saying, you're not listening. You're not really listening. You're not here on the floor. You're not paying attention to what it's actually like in this job. And decisions are getting made that impact folks in an attempt to help, but peanut buttered when that's not what people need. So I love what you were saying.
I mean, that's why I still see patients, Jenny.
Yeah.
I mean, I think that it is the best thing that you can do as a leader if you're a clinician, because I think it helps make people want to listen to you when you're telling them things, and they feel like you actually have some kind of experience to understand it. If you're removed from it, it's fine, but you can do a better job talking to them, asking them about being more transparent about things. I think that's a big thing that I'm hearing is when you try to introduce a sexy product, explaining why, or if it's taking a really long time because you have a lot of other priorities, being sure to explain that, because a lot of people who've never been in leadership or aren't hitting all the barriers to change that you might know exist don't even know that they exist. So I think there's also this do something today. Why haven't you done something today?
And hold your leaders accountable. For those of you in positions of influence and or decision making, what are you measuring your leaders on? Right? Measurement helps drive behavior, right? Are you holding the leaders accountable for their role in the well-being and the care of their workforce, right? Does it show up anywhere? Or is it only about dollars and heads? Right, so for those of you who have influence or in roles where you can make decisions, it's a question to ask. How are we measuring these things that we say we care about? Because the research that we do, the grade that our survey respondents say is they would give their organization a C- on trust that their organization can actually address burnout. C-. That is a null vote to me. That's not even a little bit confident. That's negative, neutral to negative confidence. That's a problem.
Yeah.
You don't trust your organization to actually make a change. You don't actually say, you you say the right things, but you're actually not doing the right things. You're not putting the actions behind it. So please, those of you in roles of influence and
Yeah.
decision making,
I was
please.
going to say we're going to let people ask questions
ahead.
anyway. We're at that time. So, yep.
I'm a psychotherapist who sees clients in the virtual space. And one thing I hear about people who are in burnout, that's one of the biggest issues right now, is that when they want to talk to their leadership, they don't know how. And so I think that leaders can do a great job of really shifting the power perspective, letting people know it's okay to come to us. If you have a grievance, this is how it can be handled, or if you are going to be accountable, tell me what I can do better as a leader. So that at least breaks down the resiliency you have to be placed on them, but if this ownership back of the leadership and a collaborative experience for solutions. I think that's what's missing. So they know that the employees are burned out, but then they can't tell you why. They don't feel comfortable coming to you. They don't feel comfortable with trusting the decisions out.
But then the
Is it
leaders.
Shajon? Shawan, we call that reverse coaching. You, the leader, asking your teams, what do I not know? What do I need to do differently to support this team, right? Asking reverse coaching. It's not you, the leader, coaching a junior person. It's the other way around. And I love that. Create an opening to have a dialogue. Yeah. Yeah.
And a lot of also, too, you mentioned about the huddles in the morning and a healthcare perspective. As a medical social worker, I think that's very beneficial. So you're bringing up to not only medical providers, but people who are on the front line, asking them, how's your day going, that actually use a word. And then give them some examples of a word. It's fine, it's not.
Yes.
So
Yes.
just giving different examples of leading those huddles, and then giving some autonomy, I think, to other people to lead them, not only from a power position. So even if it's the PCA, the hospital, if it's environmental services, who's on the floor every day, who speaks to people every day, they can lead those in the topics. That can make a difference.
Our nurses led the huddles in psych, so they know way more than we did.
Yeah. Yeah. I love and to add accountability to those leaders, they must, and I mean that like in terms of really concretely, they must loop back and let them know what the outcome is. Even if that includes an outcome that is not satisfactory. And I think those are the kind of things that I just so appreciate that perspective, because I think there's some accountabilities that I think require vulnerability from leadership in order to understand, again, as we said earlier, like we need to understand how the work gets done. I was a practicing clinician as well. It's been a long time. It's changed. And so I learned more, and to budget time to ensure that you have that time to have a better understanding is essential if we're really going to partner. And I think it's not a wellness program we're doing unto someone, but how do we together work together to find the best solutions? And that includes, in the innovation space, to share what didn't work.
I think one thing that, from a data perspective, so we do some work with health systems across the country on value-based contracts and accountable care and so forth, and you're always looking at what is going outside of your system. So if you offer those service lines like orthopedics, cardiovascular, why is it going somewhere else? And we see two of the biggest areas of leakage are orthopedics and behavioral health. And it goes back to the notion of trust and privacy, stigma, and so even if they offer the behavioral health services on their campus, their people are going somewhere else. And so you wonder what leadership is actually hearing and seeing, because they're not seeing it in the financial piece, And if this is a big enough issue from a financial perspective that they're losing millions of dollars, well, not millions, but thousands of dollars to competitors, then maybe they'll do something for their employees in behavioral health. But we're seeing a lot of people going somewhere else.
Well, yeah, I mean, from a clinician perspective, my peers would rather go see like an OBGYN and a urologist that we work with and see every day than a psychiatrist, right? And so it's more personal to have me know your mental health history and be in a meeting with you than the rest of those body parts, right? And that's just how it is. And so, I mean, I do internal, and I did internal psychiatry, and it was like pulling teeth, but they'd give me their dependents because they would trust their kids with me, but they wouldn't trust themselves. Other questions? I want to make sure that.
Jesse, there was one in the back and one on the side.
Oh yeah, I can't even see this. This stage is funky. Continue.
In a virtual world where we're recovering from COVID, layoffs, and just our world changed, and we're recovering.
at least in healthcare, we pick leaders for the wrong reasons sometimes too. Like, people who are chairmen are just researchers. That doesn't mean that they actually know anything about people.
Which is interesting, because I also see, just to that point, a lot more leadership development for our clinicians and physicians, because they're trying to be people managers, trying to be people leaders, and that is not a thing they learned in school. So I see a lot more in leadership programs.
I got a sign that said 5 minutes, so I'm trying not to be the one who also goes over. I don't know where the hands were.
The gentleman on the left, Jeff.
Was your hand first? You seem unconvinced. I think it's the problem he was talking about, where there's like resources, but no one knows they exist, or like they're just, it's a community. And again, we also brought it up over there, like communication issues across the board. So like you're doing a lot, but if you don't tell people what you're doing, or you're not telling them the barriers, but you also don't tell them what exists, it'll feel like there's a big disconnect.
There's a number of surveys, whether it's Business Group on Health or others, that show there's a big disconnect from what the employees are looking for in behavioral health and what the employer is actually believing that they're providing. And that's the gap you got to close. The employees are looking towards the employer to create this culture of safety and awareness around behavioral health. The employers think they're doing it, but they're not, and that's a big gap.
Monty, can I
borne
add?
out in a lot of surveys.
One email also is not the same thing as telling people. So I would tell your members, what are you doing to tell people? Because one email is one email.
Also, emails are harsh.
Yeah. So I would to Monty's point, one, is it the right thing, and also how are you telling people? Telling somebody once in an email that's like font 10, that's like 4 pages long, is like code for don't look here. So.
Yeah, I think you're right. Yeah.
Appreciate this conversation. I'm a chief wellness officer at Morris Children's Health and also a psychologist. I think in terms of the leader and the impact of the leader on the team's well-being, fortunately now in well-being we have a lot of literature that we can look to from studies that have been done. And one looking at the Mayo Leader Index showed that the team's rating of their direct leader, the higher that rating score was, the higher their well-being according to the TSI Professional Fulfillment Index. And so I do think that direct leader or manager has so much power and influence over that team's well-being. They're going to be that person to relay those resources. And like we're all saying, it's supporting those leaders. Those leaders are chosen because they're the best nurse or they're the best, physician, and they have the best, outcomes in terms of our clinical preeminence versus leadership potential necessarily. And so I think one thing our organization is starting to do and lean into is looking at leadership potential and cultivating that leadership potential through coaching for leaders and helping support them. And I just think that can extend into other types of industries as well. Is yes, we want to see the culture shift and we want to see that big organizational shift. But your everyday employee, it's that direct manager that has so much impact on how they're feeling, their flexibility and autonomy, their access to tech and things like that.
He keeps waving a sign, so I think we get like one question. I see you waving, I promise. Yeah, we'll go back there. Yeah.
It's not a question, it's more just a comment. LPC for background. Investing in DEI initiative and DEIB with belonging and having those ERGs that we can all be a part of is super exciting. And I feel like the leaders that I've worked with in the past, and I'm a leader as well, is promoting that and having that sense of belonging so that you can come to your leaders with problems that your group is in a safe space. I feel like
Well, thank you all for your awesome questions. I don't think we're running out, but he keeps putting up signs. So at least we'll be up here for like a hot second. Thank you, panelists, too.